The topic that I have been given in the next 10 minutes is what is the role of neoadjuvant therapy in the management of carcinoma stomach. Now, when I started preparing for a topic, I needed to know what are my audience. So I thought surgeons, should I discuss chemo? Should I discuss radiotherapy, both or nothing? So I said, let me discuss 10 minutes is what is relevant in this topic. Now, I'll be covering a stomach and gastroesophageal junction. Majority of the tumor or recent trends suggest that a predominant portion are now GE because of lifestyle, gastroesophageal reflux. Stomach, a very common cancer, 5th common cancer worldwide, but the most 4th common cause of death all over the world. And probably in South, we see a lot more number of CS stomach or GI cancers. In India, amongst top 5 cancers in terms of new cases all over the thing, but more particularly in Indian males. What is this? So this is G7 countries. 7 take-home message. I am a numerology believer, so 7 questions, 7 take-home message, which will make your topic clear. So let me start. Why do we need neoadjuvant therapy in carcinoma stomach? So when you look into the surgery alone data, look at stage 2A. When you look into the 5-year survival in any of the, from 2A onwards, it is less than 50%. So the moment you have, what is 2A? Any N1 becomes 2A. So once you have a node metastasis, the survival is less than 50%. So less than 50% 5-year survival, even in stage 2A. So that needs, you need more than a surgery. So why do we need, this is a common thing, you need to downstage the disease. More importantly, if you can downstage, you can get a better R0. Stomach cancer, unlike esophageal, mostly is, when you say adeno-CA, it is more a metastatic disease. So why chemotherapy scores over? Because it kills more of a micrometastasis. And when we talk about anything, if anything leads to improvement in overall survival, that is a way to go. My question number 2, whom or when should we give neoadjuvant therapy in CS stomach? So multiple guidelines, but if you have to remember, T2 onwards. In fact, these Asians, which we say Japanese, they don't follow this neoadjuvant concept because there they do screening and they operate most of the cases. But recently also they have started accepting the idea, but more so for a higher stage disease, for a take-home message, T2 and higher. My third question, what are the options available? So neoadjuvant chemo or neoadjuvant radiotherapy, and that is the most important crux of today's presentation. 3 pivotal study you have to remember, MAGIC or a British group study, a FFCD or a French group study, or a FLOT AIO, that is a German study. So let me start with the old concept because I'll tell you what is a new concept all about. So MAGIC, French study. Now try to compare the 2 study what have. More or less 2 drugs were used. What was the increment? 5-year survival was 36, 38. And there was a quantum of benefit was 13 to 14%. So 2006, 2011, 2 studies, they gave more or less the same message. 5-year survival improved by 13 to 14%. But again, these are dismal figures. 38 to 38% 5-year survival is something that we expect more. So this was the base on which we have started working on and how can we improve our overall survival in that is way. And then came the landmark study, which we still do, and that is a standard of care, which was a German AIO study. Basically a platform, what we say a backbone of FOLFOX, we had a docetaxel. So FLOT stands for 5-FU, leucovorin, oxaliplatin and taxotere. Now, this was compared with the standard of care, which was, we say, epirubicin, cisplatin, 5-FU. See the quantum of benefit. From 18 months, your progression-free or disease-free survival was 30 months with a reduction in the progression by 25%, but that is not important. So now we reach 50 months with 23% reduction in the risk of death when we compared with the standard available there. FLOT improves survival, reduces tumor better, but has its own toxicity. A word of caution is a FLOT greater response in non-diffuse type, but still we use it irrespective whether it is a diffuse or a non-diffuse type. So this became the standard of care. FLOT has more diarrhea, neutropenia, infection, neuropathy. ECF had more GI side effect and thromboembolic. Probably a fitter person needs a FLOT, so only 24% of patients were more than 70. For from tomorrow or from today, if you have a fit person, CS stomach, T2 onwards, we give FLOT. We don't think twice. What is the best option here? So the best option is, we started from surgery, 5-year survival was 23, and we reached with FLOT is 45%. Still that 45 is not even half of the 5-year survival. Then came the fourth question. By adding a radiotherapy or by substituting our chemo with radio, are we improving any of the findings? So this started because of CROSS study. CROSS was basically esophagus and GE junction. 22% was GE junction. Stomach, CTRT means radiation with weekly peclicarbo. And if you see the OS, 48 months. So 50 months FLOT, 48 months is CROSS. Which is better? So is preoperative chemo or chemo radio better? And that was answered by 3 studies. But because of shortage of time, you need to remember ESOPAC, that is German study. Now, probably those who did it never knew that there will be such a difference when you compare the two. This was an NEJM publication in this year 2025.